Hi, my name is Marissa Womble, and I work at St. Luke's North in the NICU.
Hi, my name is Amanda Cunningham, and I work at St. Luke's East in the NICU.
Hi, my name is Mindy Stone. I work at St. Luke's East in the NICU.
Hi, my name's Maria Schulmeyer, and I work at St. Luke's East in the NICU.
Our PICO question reads, would obtaining a transcutaneous Bili reading on neonates consistently compared to lab-drawn values? You may be asking, why does this matter? First, we need to explore what all goes into obtaining a serum bilirubin. The nurse will gather the supplies needed and go into the patient's room. We warm the heel for several minutes with a heel warmer to bring the blood flow to the infant's heel. Then, we pre-medicate with sucrose pacifiers to help with pain. While we are doing this, we explain what jaundice is, the neurotoxic effects it can have, and the following procedure to obtain a blood sample. During this conversation, the parents have anxiety and fear for their newborn. The last thing they want to see is their new baby in pain. As I mentioned earlier, we use sucrose pacifiers to control that pain. This recently became another dissatisfaction we have among breastfeeding mothers. It is not recommended to introduce pacifiers until breastfeeding is well established between the mother and baby. This can take days to weeks to accomplish, but this lab draw is completed within the first 48 hours of life. After explaining the benefits of the pacifier and gaining consent, the heel should be warm. We then remove the heel warmer, clean the site with alcohol, stick the heel with a lancet, and collect the blood. While the initial poke is typically the most painful, occasionally infants will have low perfusion and require more aggressive squeezing at the heel. This too can become uncomfortable for the infant and cause bruising. Once enough blood has been collected, we stop the bleeding by applying pressure with gauze, then put a Band-Aid over the site. The nurse then sends the lab down to the laboratory where we wait up to an hour for the results. Through the description I just gave, we can see the patient satisfaction scores dropping, the pain scores increasing, and we can note the plethora of supplies and their costs needed for a successful collection. All of these things for one lab draw. And this is on a term healthy infant. This brief description does not account for our preterm or high-risk infants who can have this procedure done multiple times a day, causing more stress to the infant and parents.
Hyperbilirubinemia, otherwise known as jaundice, is the most common diagnosis that leads to a hospital readmission of the newborn within the first month of life. Two common methods for determining neonatal jaundice include drawing a serum sample or by using a TCB, which is also known as a transcutaneous Bili reader. This study was used to evaluate the comparison between these two options. In this study, they evaluated 160 infants that were greater than 35 weeks and excluded babies that were less than 35 weeks or had previously been exposed to phototherapy. The transcutaneous bilirubin measurement was taken within 30 minutes of obtaining a serum bilirubin level. Serum samples were drawn via venipuncture on a peripheral vein, and 5 transcutaneous measurements were taken with the Draeger Jaundice Meter 103, also known as the JM103 meter, at the mid-sternum in a quiet child. To use the device, the meter is placed vertically on the sternum, and then gentle pressure is applied until the probe clicks. When the 5 measurements were taken, the average of the measurements would then appear in the display of the machine. In this study, all measurements on the TCB were taken by one investigator. Factors said to interfere with the accuracy of the TCB are believed to be race, gestational age, and body weight. This study, however, found that the JM103 device was not affected by birth weight, postnatal age, or sex. The study overall concluded that the use of the transcutaneous Bili reader may reduce the need for serum lab draws when determining neonatal jaundice due to its high correlation with the serum bilirubin levels.
In this study, researchers wanted to know if a transcutaneous bilirubin measurement taken from an unexposed area of the infant's skin could be a reliable substitute for serum bilirubin tests in neonates on phototherapy. If transcutaneous bilirubin measurements, also known as TCB, could be proved reliable, it would ultimately lead to a decrease in the amount of venipuncture sticks a neonate would experience during his or her hospital stay. The study consisted of 125 term neonates who were rooming in with their mothers in the hospital. The serum bilirubin tests were taken from a peripheral venous site on the infant, and the transcutaneous bilirubin test was completed by placing the meter on the infant's mid-sternum per recommendation by the Academy of American Pediatrics due to the density of the sternum on each infant. The RN performing the TCB test would turn off the phototherapy and then hold the meter in position with the white light of the meter turned on until a sound was given that the results were completed. Both the serum bilirubin level and the transcutaneous bilirubin level were measured on each infant before and during phototherapy. The results were compared using a linear regression analysis and Bland-Altman plot. The results of the study found a moderate correlation between transcutaneous bilirubin testing and serum bilirubin testing in term neonates. The study also concluded that TCB measurements were the most accurate on infants who were yet to be exposed to phototherapy due to the bilirubin light potentially affecting the white light measurement of the TCB meter even after the phototherapy treatment was turned off before testing. The study stated that TCB tests could underestimate an infant's bilirubin level by 4.3 milligrams per deciliter or overestimate the level by 2.3 milligrams per deciliter for infants already on phototherapy, specifically the infants using the Bili blanket method for phototherapy treatment. Regardless, the study concluded that even with this small inaccuracy, a TCB could still be used in between serum Bili testing to decrease the number of pokes an infant would receive during treatment, but could not be used as a complete substitute for serum bilirubin measurements.
In this study, the reliability of the transcutaneous bilirubin devices and their effects on term and near-term infants were reviewed and analyzed. Jaundice is common in newborns. Up to 10% of term and 25% of near-term neonates develop hyperbilirubinemia and require phototherapy treatment. Since serum sampling is usually done by a heel prick, this is considered painful and causes potential long-term consequences for the infant. The American Academy of Pediatrics recommends using a transcutaneous bilirubin device for jaundice screening in infants more than 35 weeks of gestation. When using a TCB device, they have shown to correlate well with serum bilirubin levels in term and preterm infants prior to the start of phototherapy and post-phototherapy phases. When assessing the diagnostic accuracy of the TCB, 14 studies were conducted providing 2,082 paired measurements in 1,319 patients. To analyze these results, correlation coefficients and Bland-Altman difference plot charts were used. However, all studies did include correlation coefficients and only 2 were Bland-Altman tests. Infants were tested on their forehead as well as their sternum, pre, during, and post-phototherapy phases. The pooled estimate of correlation coefficients during phototherapy was 0.64 to 0.75 at the forehead site and 0.43 to 0.77 at the sternum, noting better correlation of measurement at the forehead site. One of the 2 Bland-Altman difference plots showed that when tested at the forehead, the TCB underestimated the total serum bilirubin levels, and the other one showed that the TCB overestimated the total serum bilirubin levels. Both plot tests use different TCB devices. In the reviewed studies, there were also some applicability concerns. Most of the devices used are no longer used in clinical practice. There were also concerns with total serum Bili results due to laboratories only processing and resulting once a day, which could cause degradation of the bilirubin from light and heat. Several of the studies did not specify the time difference between the TCB and TSB tests. In this systematic review, with the above-mentioned considered, the results indicate that the TCB devices are much less accurate in estimating the TSB values in infants when receiving phototherapy treatment, and show somewhat improved accuracy of the TCB devices in post-phototherapy phases.
We took all of the information we gathered from our articles to come up with a recommendation, and as a group, we determined the research shows transcutaneous monitoring would be beneficial in our hospitals. While the initial cost would be larger, overall it would increase patient satisfaction scores as well as limit the amount of painful procedures our infants endure. TCB can be used during phototherapy to evaluate its effectiveness as well as infants with higher risk. This next slide looks deeper into what that recommendation means for us as a health system. In order to adopt this method into our policy, we would first need to conduct our own study. We would want to correlate our monitor with our serum lab results. Once these results were plotted out over several months and we could see our margin for error, we could then produce a new medical protocol. We can already expect a margin of overestimating up to 5 and underestimating as low as 3 points lower. The protocol would be one very similar to the glucose protocol we already use. It would read as a simple chart. For example, if an infant is 24 hours old with no risk factors and the Bili is over 7, collect a serum. We would develop this protocol with our neos and pediatricians so we know their preferences and parameters. The protocol would also be based off of Bili tool and a general rate of rise, which we already use. It would still remain at the nurse's discretion to obtain a serum at any point an infant indicates it is necessary. Once the protocol has been determined, we would then begin using the transcutaneous tool to reduce painful procedures and consequently increase our patient satisfaction scores. If anyone has questions, please feel free to reach out to any one of us. Here are our references. Thanks for watching.